During exercise, a person's heart rate increases, but the body also adjusts stroke volume and peripheral resistance. Describe how the mechanisms of the cardiac cycle, including preload, afterload, and contractility, contribute to the increased cardiac output observed during exercise. Answer: the cardiac cycle consists of systole and diastole, during which the heart undergoes phases of contraction and relaxation. During exercise, the body increases cardiac output to meet the metabolic demands of tissues. This increase is achieved by adjusting several factors. Preload: the volume of blood returning to the heart, venous return, is increased during exercise due to skeletal muscle contraction, respiratory changes, and the redistribution of blood. This increases the end diastolic volume EV, which, according to the Frank-Starling law, results in a stronger contraction due to increased myocardial stretch. Afterload: afterload refers to the resistance the heart must overcome to eject blood during systole. In exercise, peripheral vasodilation decreases vascular resistance, which reduces afterload and allows the heart to pump more efficiently. Contractility: sympathetic stimulation during exercise increases the contractility of the myocardium via the release of catecholamines, epinephrine, and norepinephrine. This increases the force of contraction, enabling more blood to be ejected per beat, increased stroke volume, thus increasing cardiac output. Explain the process of myocardial infarction (MI) and how atherosclerotic plaque rupture contributes to the development of this condition. Discuss the pathophysiological stages involved from plaque formation to infarction. Answer: myocardial infarction occurs when a portion of the heart muscle becomes ischemic due to an obstruction in one of the coronary arteries. This obstruction is often caused by the rupture of an atherosclerotic plaque, which leads to the following sequence of events. Atherosclerosis: over time, fatty streaks, cholesterol, and other materials accumulate in the walls of coronary arteries, leading to the formation of plaques. These plaques are composed of a lipid-rich core surrounded by a fibrous cap. Plaque rupture: in some cases, the fibrous cap of the plaque becomes thin and ruptures, exposing the lipid core to the bloodstream. This triggers the formation of a thrombus clot through platelet aggregation and activation of the coagulation cascade. Occlusion: the thrombus partially or completely obstructs blood flow through the affected coronary artery. This ischemic event results in reduced oxygen supply to the myocardium. Myocardial ischemia and infarction: if blood flow is not restored quickly, myocardial cells in the affected area begin to die due to lack of oxygen necrosis. The degree of infarction depends on the size of the occluded vessel and the duration of ischemia. Myocardial injury is initially reversible, subendocardial ischemia, but becomes irreversible, transmural infarction, if ischemia persists. Mrs. Carter is a 58-year-old woman who has recently been diagnosed with hypertension. Despite her adherence to lifestyle modifications, her blood pressure remains persistently elevated. Further tests reveal that she has an elevated aldosterone level and a low potassium level. What should Mrs. Carter's healthcare team consider as potential underlying causes for her hypertension, and how should they proceed with diagnosis and treatment? Answer: given Mrs. Carter's elevated aldosterone and low potassium levels, the healthcare team should consider secondary hypertension, particularly primary hyperaldosteronism, also known as Conn's syndrome, as a potential underlying cause. In primary hyperaldosteronism, the adrenal glands produce excess aldosterone, leading to sodium retention, water retention, and potassium excretion. These effects increase blood volume and blood pressure. The clinical signs are often characterized by hypertension, hypokalemia, low potassium, and metabolic alkalosis. To proceed with diagnosis and treatment, the following steps are typically taken. Confirm diagnosis. The healthcare team should order further tests such as a plasma aldosterone concentration and plasma renin activity. A high aldosterone to renin ratio is suggestive of primary hyperaldosteronism. Imaging: adrenal CT scan or MRI can be performed to identify an adrenal adenoma, a benign tumor, or adrenal hyperplasia. Treatment: if an adrenal adenoma is identified, surgical removal may be required. In cases of adrenal hyperplasia, aldosterone antagonists such as spironolactone or eplerenone are typically used to block aldosterone's effects, lowering blood pressure and correcting potassium imbalance. Discuss the role of the SA node AV node bundle of His and Purkinje fibers in the conduction of electrical impulses within the heart. How do these structures contribute to coordinated heart contraction, and what could happen if one of these structures is dysfunctional? Answer: the heart's electrical conduction system ensures the synchronized contraction of the heart muscle, facilitating effective pumping. The key components of this system include synovial node, located in the right atrium, The SA node serves as the primary pacemaker of the heart. It generates electrical impulses that set the rhythm of the heart. The normal resting rate is around 60,100 beats per minute. These impulses spread through the atria, causing atrial contraction, atrial systole, atrioventricular node. After the atria contract, the electrical impulse reaches the AV node located at the junction of the atria and ventricles. The AV node delays the impulse slightly, allowing the ventricles time to fill with blood before contraction. This delay is critical for proper ventricular filling and function. Bundle of His and bundle branches. The impulse travels from the AV node to the bundle of His, a specialized pathway that conducts the electrical signal down the interventricular septum. The bundle of His divides into the left and right bundle branches, which lead to the left and right ventricles, respectively. Purkinje fibers. The Purkinje fibers located in the walls of the ventricles rapidly conduct the impulse to the myocardial cells of the ventricles, causing them to contract ventricular systole. If any part of this conduction system is dysfunctional, it can lead to arrhythmias. For example, SA node dysfunction can result in bradycardia, slow heart rate, or sinus arrest. AV node block can delay or block the transmission of impulses from the atria to the ventricles, leading to atrioventricular AV block. Bundle branch blocks or Purkinje fiber dysfunction can lead to delayed or uncoordinated ventricular contractions. Explain the differences in structure and function between arteries, veins, and capillaries, and describe how these differences allow each type of vessel to perform its specific role in the circulatory system. Answer: the structure of blood vessels is directly related to their function in the circulatory system. Arteries. Arteries carry blood away from the heart under high pressure. They have thick muscular walls with a high proportion of elastic fibers that allow them to stretch and recoil with each heartbeat. This helps maintain blood pressure during diastole. The lumen of arteries is narrow, which helps propel blood at high velocity. Veins carry blood back to the heart under low pressure. They have thinner walls compared to arteries with less smooth muscle and more collagen. This allows veins to expand to accommodate large volumes of blood. Veins also contain one-way valves that prevent blood from flowing backward, especially in the extremities. Capillaries. Capillaries are the smallest blood vessels and are the site of nutrient and gas exchange between the blood and tissues. Their walls are only 1 cell thick, allowing for the efficient diffusion of oxygen, carbon dioxide, nutrients, and waste products. This structural differentiation ensures that blood flow is regulated according to the needs of the tissues while maintaining overall circulatory homeostasis. A patient presents with symptoms of palpitations, dizziness, and shortness of breath. The CG reveals irregular rhythm with no discernible P waves, and the ventricular rate is elevated. Based on this information, what is the most likely diagnosis, and what are the key underlying mechanisms of atrial fibrillation? Answer: the most likely diagnosis is atrial fibrillation, AF, a type of supraventricular arrhythmia. AF is characterized by the absence of normal P waves, replaced by rapid, disorganized electrical activity in the atria, leading to an irregular ventricular rhythm. The underlying mechanisms include multiple ectopic foci. In AF, rapid electrical impulses are generated by multiple ectopic foci, most commonly in the pulmonary veins, which override the normal sinus rhythm. Disrupted atrial conduction. The rapid and chaotic electrical impulses result in an effective atrial contraction, impairing the movement of blood into the ventricles. Loss of atrial kick. This can lead to blood stasis, which increases the risk of clot formation and stroke. Impaired ventricular response. The AV node attempts to filter the rapid atrial impulses, but it can't keep up, leading to an irregular and often elevated ventricular rate. Management typically involves rate or rhythm control, e.g., beta blockers, calcium channel blockers, or antiarrhythmic drugs, and anticoagulation to prevent stroke. Differentiate between left-sided heart failure and right-sided heart failure in terms of pathophysiology, symptoms, and clinical presentation. How can these two types of heart failure lead to similar and distinct clinical outcomes? Answer: left-sided heart failure primarily affects the left ventricle's ability to pump oxygenated blood to the systemic circulation. The pathophysiology includes systolic failure, reduced ejection fraction due to impaired contractility; diastolic failure, impaired ventricular filling due to stiffened heart muscle. Symptoms: pulmonary congestion due to blood backing up in the lungs, causing dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. Right-sided heart failure involves the right ventricle's inability to pump blood effectively to the lungs. It often results from left-sided failure or pulmonary diseases, e.g., COP. The pathophysiology includes peripheral edema, blood backs up into systemic circulation, causing jugular venous distension, JVD, ascites, and peripheral edema. Symptoms: fatigue, hepatomegaly, and peripheral swelling. While both types of heart failure share symptoms of fatigue and shortness of breath, left-sided failure leads to pulmonary symptoms, whereas right-sided failure leads to systemic symptom. What are the primary differences between primary and secondary hypertension, and what are some common causes of secondary hypertension? Discuss the diagnostic workup that helps differentiate the two. Answer: primary hypertension, essential hypertension, is the most common type with no identifiable cause. It develops gradually over many years and is often linked to genetic factors, lifestyle choices, and environmental factors such as obesity, physical inactivity, and high salt intake. Secondary hypertension is caused by an underlying condition that leads to high blood pressure. Common causes include renal disease, e.g., chronic kidney disease, renovascular disease, endocrine disorders, e.g., hyperaldosteronism, pheochromocytoma, Cushing's syndrome, hypothyroidism, sleep apnea medications, e.g., oral contraceptives, NSAIDs, steroids. Diagnostic workup for secondary hypertension involves testing for these underlying conditions, including renal function tests, e.g., serum creatinine, urinalysis, hormonal assays, e.g., aldosterone, cortisol, catecholamines, imaging, e.g., abdominal ultrasound, CT angiography for renal artery stenosis. A 62-year-old male patient with a history of coronary artery disease (CAD) undergoes a stress test on a treadmill. The test is terminated at 6 meters TS due to fatigue, and the ECG shows segment depression. The patient reports mild chest discomfort during exercise. How should the results of this stress test be interpreted, and what are the next steps in management? Answer: the patient's stress test results suggest exercise-induced ischemia, as indicated by segment depression on the ECG, a hallmark of myocardial ischemia. The presence of chest discomfort during exercise, which may indicate angina. The test was terminated at 6 meters TS, the moderate level of exertion, which suggests the patient was unable to achieve their predicted exercise capacity, a potential sign of exercise intolerance related to CAD. Next steps in management include risk stratification. Given the patient's CAD history, the presence of symptoms and ECG changes during the test, further risk assessment is warranted to determine the severity of ischemia. Referral for coronary angiography. If the patient is symptomatic and stress test results are indicative of significant ischemia, coronary angiography may be indicated to assess the extent of blockages and consider revascularization options. Lifestyle modifications. Continued management of CAD with emphasis on smoking cessation, diet, exercise, and blood pressure control. Discuss the role of nutrition in cardiac rehabilitation with a focus on the impact of dietary modifications on lipid profiles, blood pressure, and overall cardiovascular risk. How would you guide a patient with dyslipidemia through dietary changes to improve cardiovascular health? Answer: nutrition plays a key role in cardiac rehabilitation, particularly in managing dyslipidemia, hypertension, and overall cardiovascular risk. Specific dietary modifications include reduction in saturated fats. Reducing the intake of saturated fats found in animal products and processed foods can help lower LDL cholesterol levels and reduce the risk of atherosclerosis. Increase in omega-3 fatty acids. Consumption of omega-3 fatty acids found in fatty fish like salmon, flax seeds, and walnuts has been shown to reduce triglyceride levels, lower blood pressure, and improve overall lipid profiles. Increased fiber intake. A diet high in soluble fiber from fruits, vegetables, legumes, and whole grains can help lower cholesterol levels, particularly LDL cholesterol, and improve blood sugar regulation. Sodium reduction. Reducing sodium intake is essential for controlling blood pressure. The DASH, dietary approaches to stop hypertension. Diet emphasizes low sodium intake and encourages fruits, vegetables, and whole grains to reduce hypertension. Plant-based diet. Emphasizing plant-based foods and reducing animal products can lower cholesterol, blood pressure, and inflammation. When guiding a patient with dyslipidemia, you would assess current dietary habits, identify areas for improvement, such as excessive saturated fat or refined sugar intake, set realistic goals, encourage gradual changes such as reducing fried foods, increasing fish consumption, or replacing refined grains with whole grains, provide resources, offer meal planning ideas, recipes, and potentially refer to a dietitian for personalized advice, monitor progress, follow up with lipid panel tests to assess the effectiveness of dietary changes in improving lipid profiles. What are the critical components that should be included in a comprehensive medical history and physical examination for risk stratification in cardiac rehabilitation? Discuss how these factors influence the risk assessment and subsequent rehabilitation plan. Answer: A thorough medical history and physical examination form the cornerstone of risk stratification in cardiac rehabilitation. Key components include medical history, past cardiovascular events, e.g., myocardial infarction, stroke, comorbidities, e.g., diabetes, hypertension, lifestyle factors, e.g., smoking, diet, exercise, and family history of heart disease. Physical examination includes assessing vital signs, heart rate, blood pressure, auscultation for heart murmurs or abnormal rhythms, and inspection for peripheral edema or signs of heart failure. Influence on risk assessment. A patient with multiple comorbidities, previous cardiac events, or signs of heart failure, e.g., edema, crackles in the lungs, may be categorized as high risk. This will dictate a more cautious and structured rehabilitation approach, including close monitoring, a slow progression of exercise intensity, and appropriate pharmacological management. Protocols and guidelines. The American Heart Association and American College of Cardiology Act provide guidelines for assessing these factors. For instance, a history of myocardial infarction increases the likelihood of complications during exercise, necessitating a more conservative approach in phase I rehabilitation. Explain the role of stress testing, e.g., Bruce Protocol, nuclear stress testing in risk stratification for patients in cardiac rehabilitation. What factors should be considered when selecting the appropriate stress test for a patient? Answer. Stress testing is critical in assessing a patient's functional capacity, identifying coronary artery disease, and evaluating the cardiovascular system's response to exertion. Bruce Protocol. A treadmill-based exercise test where the intensity increases every 3 minutes. It is widely used to assess exercise tolerance, heart rate response, and ECG abnormalities. Nuclear stress testing involves the injection of a radioactive isotope to assess myocardial perfusion during stress and at rest. This is especially useful for detecting ischemia and evaluating the severity of coronary artery disease. Selection factors. The choice of stress test depends on the patient's clinical presentation. For example, a patient with a high risk of myocardial infarction or significant coronary artery disease may require nuclear stress testing for better sensitivity. Alternatively, low-risk patients or those with no symptoms may be appropriately tested using the Bruce Protocol. Clinical guidelines. The AHOC guidelines suggest using exercise stress tests for patients without symptoms or in low-risk categories, whereas nuclear stress testing is more appropriate for those at high risk or with equivocal results from an exercise test. Mr. Thompson, a 58-year-old male, underwent a coronary artery bypass grafting (CABG) surgery following a myocardial infarction. On the second postoperative day, his cardiologist orders mobilization to begin. What steps should the rehabilitation team take to initiate phase I rehabilitation, and what precautions must be followed? Answer. In phase I inpatient care, the primary goal is to initiate early ambulation and bedside mobility exercises, which help reduce complications like deep vein thrombosis, pulmonary embolism, and muscle weakness. Initial steps. Begin with passive range of motion, ROM exercises in bed, progressing to active ROM as tolerated. Gradually introduce sitting up on the side of the bed, followed by sitting for longer periods. Ambulation should begin with short, supervised walks, progressing in distance and time based on tolerance. Precautions, monitoring. Continuous monitoring of heart rate, blood pressure, and oxygen saturation is essential during ambulation. Pain management. Any signs of chest pain, dizziness, or discomfort should result in halting the exercise. Surgical site. Protect the chest incision area to avoid strain. In phase I cardiac rehabilitation, what are the key components of an outpatient rehabilitation program for patients post-myocardial infarction, and how is supervised telemetry monitoring incorporated to enhance patient safety during exercise? Answer. Phase I cardiac rehabilitation is designed to provide supervised exercise training, education, and risk factor modification to improve cardiovascular health and prevent future events. Key components: aerobic exercise, tailored to the patient's tolerance, usually beginning with low-intensity walking or cycling. The goal is to improve cardiovascular fitness and endurance. Resistance training. Light resistance exercises are introduced to build muscle strength, generally starting after a few weeks of aerobic exercise. Education focuses on lifestyle modifications such as smoking cessation, dietary changes, and stress management. Risk factor management, addressing hypertension, diabetes, and lipid management through medication, exercise, and nutrition. Supervised telemetry monitoring. Telemetry monitoring during exercise allows healthcare professionals to continuously assess heart rate, rhythm, and other vital signs during the session. This ensures early detection of arrhythmias, ischemia, or other exercise-induced complications. What is VOMAX and how is it used in evaluating a patient's functional capacity in cardiac rehabilitation? Discuss how VOMAX influences the intensity of prescribed exercise programs. Answer: VOMAX is the maximum amount of oxygen a person can utilize during intense exercise measured in milliliters of oxygen per kilogram of body weight per minute abdomen. It serves as an indicator of aerobic capacity and cardiovascular fitness. Role in cardiac rehabilitation. VOMAX is a critical measure for assessing a patient's functional capacity and cardiovascular health. Higher VOMAX values indicate better aerobic fitness and a low risk of cardiovascular events. For example, a patient with a VOMAX of 20 abdomen is considered deconditioned and a low-intensity exercise program is indicated. In contrast, a patient with a VOMAX of 4 abdomen may progress to moderate or vigorous intensity exercise. Exercise intensity. VOMAX directly influences the target intensity for exercise prescriptions. Based on a percentage of VOMAX, usually 4085%, rehabilitation programs are designed to improve cardiorespiratory endurance. A program may start at lower intensities for patients with low VOMAX and gradually increases their aerobic capacity improves. What are the key elements of transitioning a patient from phase II maintenance to phase IV lifestyle integration in cardiac rehabilitation? Discuss the challenges and strategies for promoting long-term adherence to an exercise regimen. Answer: transitioning from phase II to phase IV focuses on empowering patients to maintain the benefits of cardiac rehabilitation independently. Key elements: exercise independence. Patients are encouraged to continue their exercise routines independently or through community-based programs. Behavioral strategies emphasize motivation through goal setting, support groups, and regular follow-ups. Ongoing risk factor management. Continue addressing modifiable risk factors such as diet, smoking, and stress. Challenges. Motivation. Long-term adherence can be difficult due to lack of immediate rewards or perceived barriers like time constraints. Health literacy. Ensuring the patient understands the importance of regular exercise and self-management. Strategies for success. Encourage participation in local fitness programs or group activities for social support. Provide continuous monitoring and follow-up, even in phase IV, through phone calls or occasional check-ins. Promote self-monitoring and awareness of symptoms that may necessitate medical evaluation. Clinical guidelines. AHOC recommend maintaining regular contact with patients even after they transition to phase IV to ensure continued adherence to lifestyle changes and exercise. Explain how the Framingham Risk Score is used to assess cardiovascular risk and its limitations in guiding exercise prescription in cardiac rehabilitation. Answer: the Framingham Risk Score (FRS) is a tool used to estimate a patient's 10-year risk of developing cardiovascular disease (CVD) based on factors like age, gender, cholesterol levels, smoking, blood pressure, and diabetes status. Use in cardiac rehabilitation. The FRS helps determine the patient's overall risk category, low, intermediate, high, guiding the intensity and monitoring level of exercise. A high-risk patient may require more intensive monitoring during exercise and a conservative approach to exercise progression. Limitations. Generalization. The FRS may not be as accurate for individuals with atypical risk factors or those with a family history of premature CVD. Excludes functional capacity. The FRS does not incorporate a patient's exercise capacity such as VOMAX, which is critical for personalized exercise prescription. Clinical guidelines. The AHA and ACC recommend the use of the FRS as a preliminary screening tool but advocate for more individualized assessments including functional tests and stress testing for exercise prescription. What are the primary considerations and monitoring strategies for patients who have recently undergone a myocardial infarction, or heart surgery during phase I rehabilitation? Answer: post-MI or post-surgical patients require close monitoring during rehabilitation to prevent complications like arrhythmias, excessive myocardial stress, and ischemia. Primary considerations: vital signs monitoring. Continuous monitoring of heart rate, blood pressure, and oxygen saturation is critical to detect any signs of ischemia or arrhythmia during activity. Pain and fatigue assessment. Any chest pain, shortness of breath, or dizziness should prompt immediate cessation of activity. Activity tolerance. Patients should only progress to higher intensity activities when they can safely tolerate lower intensity exercises. Monitoring strategies. Telemetry. Continuity. CG monitoring ensures early detection of arrhythmias or other abnormal rhythms. Exercise intensity. Use of perceived exertion scales, e.g., Borg scale, and heart rate targets based on patient condition. Discuss the role of echocardiography and CT angiography in evaluating cardiovascular disease severity and guiding rehabilitation strategies in patients post-acute coronary syndrome. Answer: echocardiography and CT angiography are crucial diagnostic tools in assessing the severity of cardiovascular disease and guiding rehabilitation strategies. Echocardiography: non-invasive imaging used to assess cardiac structure, function, and blood flow. It helps identify issues like left ventricular dysfunction, valve abnormalities, or regional wall motion abnormalities, which may affect exercise capacity and guide rehabilitation intensity. CT angiography provides detailed imaging of coronary arteries, helping assess the presence and extent of coronary artery disease (CAD). It is especially valuable in patients with intermediate risk or those who have inconclusive results from other tests. Clinical use in rehabilitation. Echocardiography may prompt the adjustment of rehabilitation goals, especially if significant left ventricular dysfunction is present. CT angiography may indicate the need for further medical management, including revascularization procedures before proceeding with higher intensity exercise. Clinical guidelines. IAHOC recommend imaging in cases of ambiguous symptoms or when detailed coronary anatomy is needed to guide treatment and rehabilitation. What is the rationale behind including both aerobic and resistance training in phase I cardiac rehabilitation? How do these two forms of exercise complement each other for improving cardiovascular health? Answer: both aerobic and resistance training play distinct roles in improving cardiovascular health and physical fitness in cardiac rehabilitation. Aerobic training primarily aims to improve cardiovascular fitness, increasing cardiac output, stroke volume, and overall aerobic capacity. It enhances the efficiency of the heart and lungs, which is critical for long-term cardiovascular health. Resistance training strengthens muscles, improves muscular endurance, and supports the prevention of frailty, especially in older patients or those with weakened cardiac function. It also helps manage other risk factors such as hypertension and diabetes by improving insulin sensitivity and reducing body fat. Complementary effects. While aerobic exercise improves heart function and efficiency, resistance training supports overall muscular health, enabling patients to engage in daily activities with greater ease and reducing the risk of functional decline. Together, they provide a holistic approach to improving both cardiovascular and muscular health. Clinical guidelines. The AHOC recommend including both types of exercise in phase I rehabilitation for comprehensive cardiovascular and musculoskeletal benefits. IACAHA guidelines emphasize tailoring post-myocardiac rehabilitation (CR) programs. What are the core components of CR as defined in these guidelines, and why are they critical in secondary prevention? Answer: the IACAHA guidelines identify the following core components of CR programs: medical evaluation and risk stratification. Helps to determine exercise tolerance, underlying risks, and any comorbidities to individualize programs. Exercise training focuses on improving cardiorespiratory fitness, which reduces mortality and enhances functional capacity. Nutritional counseling addresses dietary habits to manage cholesterol, blood pressure, and weight. Psychosocial support includes screening for depression and anxiety, common post-MI conditions, and fostering adherence to CR. Smoking cessation support. Tobacco use is a leading cause of recurrent MI. Smoking cessation counseling and pharmacotherapy can significantly reduce risks. Risk factor management addresses hypertension, dyslipidemia, and diabetes control as primary components of secondary prevention. Relevant guidelines. IACAHA Task Force Report 2020 recommends structured programs incorporating these elements to achieve at least a 20% reduction in recurrent cardiovascular events. Mrs. Patel, a 72-year-old patient with a history of CABG and diabetes, is referred to a CR program. During her initial assessment, you notice she has mild neuropathy affecting her balance and reports occasional hypoglycemic episodes. What specific modifications should her CR program include? Answer: balance and stability training includes seated or supported exercises to prevent falls. Tai Chi or balance-focused interventions can be beneficial. Modified exercise intensity use at lower intensity range, 40% 60% of heart rate reserve based on her frailty and reduced tolerance due to age and neuropathy. Blood glucose monitoring. Ensure pre-exercise blood glucose is between 100-25 EDL. Avoid exercise if below 100 mdl or above 300 mdl. Duration and frequency adjustments. Shorter, more frequent sessions. G1520 minutes, 5 days may be better tolerated. Foot care education. Advise on wearing appropriate footwear to prevent pressure sores or injuries. Nutrition coordination. Work with a dietitian to manage carbohydrate intake around exercise to minimize hypoglycemia risks. Relevant guidelines. American Diabetes Association (ADA) recommends specific glucose monitoring protocols for patients with diabetes in exercise programs. Describe how ESC recommendations for secondary prevention integrate the use of pharmacotherapy in cardiac rehabilitation, and explain the rationale behind these integrations. Answer: ESC recommendations integrate pharmacotherapy into cardiac rehabilitation to stabilize cardiovascular risk factors. Beta blockers reduce myocardial oxygen demand and control heart rate. ACE inhibitor subs improve ventricular remodeling and reduce mortality and heart failure. Statins lower LDL cholesterol levels, reducing plaque progression, enhance adherence to lifestyle modifications. Medications can complement lifestyle changes in controlling hypertension and lipid levels, especially in patients resistant to lifestyle-only modifications. Prevent thrombotic events. Antiplatelet agents e.g. aspirin, PI inhibitors, critical after PCI or stenting to reduce clot formation. Rationale: pharmacotherapy addresses the biological mechanisms underlying cardiovascular disease (CVD), such as inflammation, hyperlipidemia, and hypercoagulability, while CR addresses modifiable behavioral factors. Together, these interventions lower recurrent event risks by approximately 40% when appropriately combined. Mr. Johnson, a 65-year-old PCI patient with significant depressive symptoms, has been reluctant to attend CR sessions. He argues that it won't make a difference anyway. How should the CR team approach his care to improve his adherence and outcomes? Answer: psychosocial assessment and counseling. Conduct a detailed evaluation using validated tools. A PHQ-9 to assess depression severity. Engage multidisciplinary support. Involve a psychologist or counselor for cognitive behavioral therapy (CBT) to address his negative beliefs about CR. Motivational interviewing. Use patient-centered communication to explore and resolve ambivalence, emphasizing small, achievable goals. Leverage peer support. Connect Mr. Johnson with support groups or peer mentors who can share positive outcomes from CR participation. Medical management of depression. Collaborate with his primary care physician or psychiatrist to optimize antidepressant therapy if needed. Relevant guidelines. ACAHA 2020 recognizes psychosocial support as a core CR component and underscores its role in improving adherence. European Society of Cardiology suggests integrating mental health strategies into CR programs. How should exercise programs for LVAD patients in a CR setting be structured, and what precautions are necessary? Answer: exercise program structure, warm up and cool down. Essential to prevent sudden hemodynamic shifts. Aerobic training. Use moderate intensity exercises e.g. walking or cycling with close monitoring of perceived exertion. Target RPE 1113. Strength training. Focus on low resistance, high repetition exercises to maintain muscle mass without imposing strain on the device. Avoid isometric exercises. These can increase afterload and negatively impact device performance. Precautions. Continuous monitoring. Assess device parameters e.g. flow rate, power, and alarms before and after exercise. Avoid dehydration. Dehydration can impair LVAD function due to reduced preload. Emergency protocols. Ensure staff are trained to manage device alarms and know emergency protocols. Why is it essential to monitor for autonomic dysfunction in patients undergoing cardiac rehabilitation, especially those with a history of MI, and how should this affect their exercise programming? Answer: autonomic dysfunction, common in patients after MI, impairs the regulation of heart rate, blood pressure, and vascular tone, which can lead to complications such as postural hypotension, arrhythmias, and exercise intolerance. It's crucial to monitor autonomic function to prevent these adverse effects during cardiac rehabilitation. Key considerations in exercise programming for these patients. Gradual progression. Start with low-intensity exercise e.g. walking, and gradually increase intensity as tolerated. Frequent rest breaks. Provide opportunities for rest to manage the risk of orthostatic hypotension or dizziness. Heart rate monitoring. Continuous ECG monitoring during exercise to detect arrhythmias is critical. Hydration. Ensure adequate hydration to support circulatory function and prevent low blood pressure. Relevant guidelines. CAHA Guidelines 2020. Mr. Thompson, a 58-year-old patient with a history of diabetes and moderate chronic kidney disease (CKD), is referred for cardiac rehabilitation following a recent PCI. He reports that he often feels fatigued and experiences swelling in his ankles. Given his medical history, what are the primary concerns you should address in designing his rehabilitation program, and what specific adjustments are necessary? Answer: Primary concerns: renal function and fluid balance. CKD patients may struggle with fluid retention, and excessive exercise may exacerbate swelling or cause dehydration. Blood glucose control. Diabetes can affect exercise tolerance, and Mr. Thompson is at risk for both hypoglycemia and hypoglycemia during physical activity. Cardiovascular risk management. His recent PCI and diabetes place him at increased risk of cardiovascular events. Adjustments in rehabilitation program. Exercise intensity and monitoring. Exercise should be low to moderate intensity, e.g. 40% 60% of Vmax to reduce strain on both the heart and kidneys. Close monitoring of heart rate and blood pressure is essential. Fluid management. Careful management of hydration is crucial, especially since CKD patients may have issues with fluid retention or dehydration. Avoid excessive water intake during exercise. Blood glucose monitoring. Ensure that blood glucose levels are monitored before and after exercise. The target pre-exercise glucose should be between 100-25 a year. What role do psychotropic medications play in cardiac rehabilitation, and what considerations should be made when prescribing exercise for patients on such medications? Answer: Psychotropic medications, such as antidepressants, anxiolytics, and antipsychotics, are commonly prescribed in cardiac rehabilitation to manage symptoms of depression, anxiety, and other mood disorders, all of which can impact recovery. However, these medications can have significant effects on cardiovascular function and exercise capacity. Key considerations: sedation and fatigue. Many psychotropic medications, e.g. benzodiazepines, tricyclic antidepressants, can cause sedation, leading to decreased exercise tolerance. Exercise intensity should be adjusted based on the patient's energy levels, heart rate, and blood pressure effects. Some antidepressants, especially SRIs and SNRIs, may cause orthostatic hypotension or arrhythmias, requiring careful monitoring of vital signs during exercise. Side effects of antipsychotics. Antipsychotics can cause weight gain, metabolic syndrome, and cardiovascular issues, which should be addressed with lifestyle modifications in rehabilitation. Medication timing. It's critical to consider the timing of medication doses to avoid peak sedation or side effects during exercise. Mrs. Garcia, a 64-year-old patient with a history of valve replacement surgery, presents for evaluation in your cardiac rehabilitation program. She mentions that she occasionally experiences shortness of breath and fatigue during mild exertion. How would you approach her exercise prescription, and what special precautions should you consider for a patient with a mechanical heart valve? Answer: Approach to exercise prescription. Initial assessment. Conduct a comprehensive assessment of Mrs. Garcia's current functional capacity using tools such as the 6-minute walk test or functional aerobic capacity tests. Exercise intensity. For a post-valve replacement patient, begin with low-intensity aerobic exercises, walking, cycling at 40% 60% of heart rate reserve. HRR gradually progressed as tolerated, aiming for 30-60 minutes of moderate intensity exercise 5 days a week. Monitor shortness of breath. Ensure close monitoring for signs of exercise intolerance, e.g. breathlessness, fatigue, and adjust exercise intensity accordingly. Special precautions for mechanical heart valve. Anticoagulation therapy. Mrs. Garcia is likely on anticoagulants, e.g. warfarin, to prevent thromboembolism. Exercise can increase bleeding risk, especially with high-intensity exercise. Monitor for signs of bleeding or bruising. Increased risk of endocarditis. Mechanical valve patients are at risk for infective endocarditis. Therefore, ensure that exercise settings are free from infection risk and recommend prophylactic antibiotics before any invasive procedures or intense activities. How do gender differences affect the presentation and management of cardiovascular disease in cardiac rehabilitation, and what specific adjustments should be made for female patients in CR programs? Answer: Gender differences in cardiovascular disease (CVD) have significant implications for cardiac rehabilitation. Women often present with more atypical symptoms and may have different risk profiles compared to men. Key considerations include presentation differences, symptomatology. Women are more likely to experience non-chest pain symptoms, nausea, fatigue, shortness of breath during an acute MI. This makes early diagnosis more challenging. Risk factors: women often have hypertension as the leading risk factor, whereas men may present with more traditional risk factors like high cholesterol. Women also tend to develop CVD at a later age, and diabetes is a more significant risk factor for women than men. Adjustments in CR for women: screening for depression and anxiety. Women are more likely to experience depression post-MI. Incorporating psychosocial support is critical for improving outcomes. Hormonal considerations: hormonal changes, e.g., menopause, impact CVD risk, necessitating close monitoring for conditions like osteoporosis and arterial stiffness, which are more prevalent in postmenopausal women.